cohort study on the clinical features and outcomes of Pseudomonas stacheri bacteremia in medicine wards, including ICU, in a tertiary care teaching hospital. Pseudomonas stacheri is a gram-negative saprophyte organism that is infrequently known to cause hospital-acquired infections. They're usually isolated from soil, and in the recent years, we've been isolating them from hospital-acquired infections, main sources being blood, respiratory tract, including urine also. So the aim of the study is primarily to look at the clinical profile of patients who were admitted with Pseudomonas stacheri bacteremia, and if they had a poor outcome, to look at what were the risk factors which were associated with a poor outcome. So we, over the last 10 years, we've isolated 31 cases of Pseudomonas stacheri bacteremia in our medicine ward. The study was approved by IRB, and we extracted the clinical data from the electronic medical records that are there. The data was entered into Epidata, and analysis was done using SPSS software. So during the study period, 31 cases were isolated, 45% of it being male, 55 approximately being female. Looking into the outcomes that we had looked, 42%, 43% approximately of patients who had a poor mortality, poor outcome, including mortality as well as discharge against medical advice, were actually diabetic, hypertension being the second most common comorbidity. Primary source of infection being lung infections, followed by unidentified source of sepsis. Poorer outcomes were noted in patients who had prolonged ICU stay. Around 43% of patients who had a poor outcome had a prolonged ICU stay, and around 57% of poor outcome patients had mechanical ventilations. Primarily, all of them were treated with two antibiotics, meropenem as well as piperacillin tazobactam. 16% of the total patients, that is of the 31 patients we had seen, had a concurrent other organism that was isolated. The conclusion is Pseudomonas stacheri appears to be an emerging pathogenic bacteria, causing approximately a mortality of around 22% in our study. However, the exact causal association needs to be studied further with respect to sepsis and mortality. The direct causality cannot be associated, so RCT needs to be done in the future for this. For clinicians, the two things that we can look in, this is a hospital-acquired infection, so strict protocol, adherence to an HICC protocol is essential. And as clinicians, if we have Pseudomonas stacheri bacteremia, to look at the risk factors, if the patient is having an uncontrolled diabetic, is immunosuppressed, has a prolonged ICU stay with ventilation, it might be worthwhile to treat it and not just consider that as a commensal. Thank you.
Just a question. Your conclusion is that this bacteria is of increasing trend. How did you determine the trend?
So over the last 10 years that we had looked at, from 2014 to around 2020, we had just 3 cases. Rest of the 31 cases that we have of the rest have been actually isolated post 2020 to 24 within that time.
And that is the numerator, isn't it?
Yes.
When you look at the trend, numerator is alone, it doesn't make sense. Because numerator, it's a proportion of the total number of hospital-acquired infections should be the numerator. Without denominator, you cannot make trend. Suppose you had much more admissions, and see you have to understand it's the proportion of this bacteria among the infection which is the trend, not the number.
You know what? Yeah, what you're trying to say, Krupa, is that it is Pseudomonas non-aeruginosa strain. Okay, doesn't matter whatever the name is, etc. And you found a bacteremia over 10 years, not a problem in 20 patients, so it's not an epidemic, etc. And just rewrite that. Don't say undifferentiated infections. Source is not known.
Yes. Sure.
Okay, you may not know the source from lung. You'll know, etc. And you should always, whenever you use a bacteria in any description, you must give the susceptibility.
Yes.
Based on the susceptibility only, you can say good outcome or bad outcome. If you have a non-susceptible strain, chances are it will be a poor outcome. So you have to see whether good outcome is a measure. Only then you will learn.
Yes.
If a strain is susceptible to meropenem, why on earth should I die? Okay. Second one is, please take it out of your mind. You will never be able to do a randomized controlled trial with very few organisms of 20 in 10 years. So you try to better your own treatment as such. Okay, Pseudomonas non-aeruginosa, drug of choice is meropenem. But how you use pip-tazo, I don't know. By definition, pip-tazo should not act against Pseudomonas non-aeruginosa strains. I don't know, but you just check it out. Okay, as such. And otherwise, it's okay. And you should see where the yeah, that's the only comment.
Thank you, sir.